Welcome back, everyone. We're going to continue our Neurologic series in this lecture with discussing seizures. As mentioned in the altered mental status lecture, seizures are among the most common complaints that we see within EMS and can be terrifying as both a patient, a family member, a bystander, or a provider to witness. Hopefully through this lecture we can discuss some of the types of seizures and help build your confidence in how to manage these seizures and kind of what to expect for some of these patients. Let's start with some definitions. A seizure is a neurologic episode that's caused by essentially a surge of electrical activity in the brain. There are actually several different types of seizures depending on where that electrical activity is at within the brain. Most of us are familiar with the generalized seizures, or what used to be called the tonic-clonic seizures, and that's the whole body convulsions that occur during the seizure episode. But there are also other types of seizures, and they're generally categorized as focal or partial seizures. And fundamentally, these are the same. They're electrical activity within the brain that is sort of awry, but it's within a narrow focused place within the brain. So let's start by looking at the general seizures, or the tonic-clonic seizures. Generalized seizures result from electrical discharges across large areas of the brain. So you can see on the bottom image there of the right-hand side of your screen, the electrical foci within the brain of the seizure is everywhere, right? It's occurring all over the place, and that's what causes sort of a global body response. They're typically characterized by unconsciousness and generalized severe twitching of all the muscles, and it can last several minutes or longer. While focal seizures tend to focus on a specific area of the body where you see the movement, or you may experience no movement at all, such as in absent seizures, which we'll talk about here in just a few minutes. By and large, the seizure in itself is not a life-threatening event. Most seizures are self-limiting. When a seizure becomes a life-threatening event is when it doesn't become self-limiting or it continues on for an extended period of time. Other factors that may result in sort of lethal complications of seizures are trauma associated with the patient. So if the patient was standing in a position or had a seizure while, say, crossing the street, for example, the secondary trauma associated with that seizure event can certainly be life-threatening. And then untreated seizures for long periods of time can result in states of profound hypoxia and hypoglycemia, which can obviously complicate the patient's presentation, or the seizure being a symptom of a life-threatening underlying condition such as a stroke or increased intracranial pressure from a head injury. If the seizure lasts long enough, cerebral glucose and oxygen will be depleted. And for generalized seizure patients, we'll talk about a postictal period. This is often where some of that confusion comes from, is the lack of glucose and oxygen that the brain is able to readily use. That also is generally self-limiting, but we can help speed that process along by supplying some oxygen to the patient in that postictal state. The pearls for treating a patient having a seizure. One is going to be let them sort of make sure they're in a safe area. Don't try and restrain them. But as I mentioned earlier, the seizure itself isn't life-threatening. It's the complications, the lack of ventilation and the lack of oxygenation that occurs. And so even if a patient is in a prolonged seizure and your provider level, you don't have the medications with the ability to break that seizure, or if you're an advanced level provider and you've administered anti-epileptic medications with no effect, you need to ventilate these patients and oxygenate these patients, because as they are seizing, their diaphragm is also seizing, so they're not off-gassing carbon dioxide and they're not ventilating oxygen. So treatment pearl there is for prolonged seizures: oxygenate, ventilate, make sure these patients can engage in gas exchange so we don't further complicate their condition. For this next slide, I want to take a look at an absent seizure. An absent seizure is a type of seizure where there's not a lot of gross motor movement across the body. Rather, it's hallmarked by a period of the patient being completely unresponsive. They still maintain motor tone, so they'll be standing upright, but the patient won't engage most of the time with any stimulus in their outside environment. So I'm going to pause just a second and play this short video from the LGS Foundation because it's not something that you would typically think of as a lay provider or lay person as a seizure, but this is a definite seizure event here.
Hey, look over here at me. What you doing, Bubby? Hey. Brian. Brian. Hey, come on, babe. Hey. Brian. Bubby, you just said it on the counter. Hey. Brian, look here. Brian. Hey, hi. How are you?
You can see at the very end there that the patient is in a state of confusion, and that state of confusion is that postictal state. That postictal state is a period where the patient is coming back to, but has significant confusion about the surroundings and that area around them. These general seizures are usually hallmarked by that postictal state. And you can see that the patient doesn't appear to be in any severe emergency, but is not engaging with outside environment whatsoever until there. And you can note the confusion on the patient's face. That's an absent seizure. The other types of seizure we can see are partial seizures or focal seizures. These are seizures that don't impact the entirety of the body. However, they impact sections of the body, and it may be hemi affected, or one side of the body. It may be just a hand twitch or an eye twitch, or facial muscle may twitch. There's no changes typically in the patient's level of consciousness, although there may be some panic that's associated with this. So the patient may be scared. The patient may not understand what's going on, especially if this is a new onset seizure. So it's important to provide support for these patients, especially emotional support. If the partial seizure is impacting the patient's airway, then airway protection is going to be extremely important here. So tonic-clonic or generalized seizures are all over the place. You have absence seizures, which is the video that we just watched with the child there. And then you have focal seizures, which may be a small part of the body. There's a specific type of focal seizures that you need to be aware of as well. These are called Jacksonian March seizures. And they're focal seizures that divulge into full generalized tonic-clonic seizure. So they may start with a twitching of a hand, and then it may move up to the arm, and then it may be affecting the entire right or left side of the body, and then they move into a state of full generalized seizure. And that's just a type of seizure, a type of focal seizure called a Jacksonian March seizure. Focal onset seizures, they do often impair some awareness. And so, again, not just emotional support, but you need to make sure that the patients are in an environment where they're not going to hurt themselves. Under no circumstances should you ever try and restrain a seizing patient that's actively seizing. We'll talk about some of the advanced care for seizures for paramedic providers a little bit later. But for the basic level providers or even advanced EMT level providers, make sure the patients have the ability to move and seize in an environment where they're free from danger, but you should never try to hold that patient down. Generally, prior to a patient having a seizure, particularly if they have seizures regularly within their life, there may be a period of time just preceding the seizure called the aura. This aura phase can include things like visual changes or hallucinations. The aura phase for the patient is usually different for most every patient, and a patient who has a history of epilepsy will note this aura phase and move themselves to a position to be able to seize. And so if you're transporting an epileptic patient or you're treating an epileptic patient and they say something or do something like just lay down on the floor, or they lay down, or they say, I'm getting ready to have a seizure, you should expect them to have a seizure. Again, if you're witnessing a seizure from start time, they should last less than 30 to 60 seconds. They really don't last that long. It seems a lot longer. You should gauge the time of seizure activity. And if you've arrived on scene and a patient is in that confused postictal state, you should ask the bystanders, if they are there, how long the seizure lasted. That's an important part of history for that patient, as the length of seizure will help determine the impact of hypoxia and hypoglycemia and other metabolic changes that occur within that patient. But if the patient is in that aura phase and they indicate that they're getting ready to have a seizure, make sure that they have a safe place to engage in that seizure activity and let them go through that process. If the seizure is lasting longer than 2, 3, 4 minutes, you may need to consider oxygenation. And if it's lasting up into that 4-minute range, you probably should start to consider ventilation. And that patient may be moving into a state called status epilepticus, which we'll talk about more here shortly. Let's talk a bit about pseudo-seizures. And pseudo-seizures is sort of an old term. And it really is not a great term to be able to use, and we really shouldn't be using it. And it's somewhat disappointing that still is pervasive within EMS and the profession. The more appropriate term would be epileptic seizures for focal seizures, absent seizures, generalized seizures, and then we have non-epileptic events or non-epileptic seizure activity. It was long thought that pseudo-seizures were the patient's cognitive attempt to fake activity to gain attention, and that really is just not the case. There is an entire branch of medicine and studying non-epileptic seizure events or seizure-like events that are well beyond the patient's control. These can be things like conversion disorders, triggers from stress, stimulus, flashing lights, a number of things. They don't always occur, and the notes here on the left-hand side of the slide are from current curriculum and text, and it says that pseudo-seizures occur with a witness. That's not always true. And the motion is relatively organized, and that also isn't always true. Pseudo-seizures, the old term pseudo-seizures was used to describe someone who was faking intentionally a seizure, and that's just not the case. PNEA, or these psychogenic non-epileptic attacks, do have some differences. They may have recall events. The episodes may last longer. Unlike epileptic seizures, lacerations to the tongue and the cheek are not as common. But there are underlying EEG changes and metabolic changes that occur within these patients. And this is not a well understood side of medicine, and there's still a lot of studying that's going on. I would encourage you as an informed provider to go out and find some more recent information on psychogenic non-epileptic attacks and take a look at this. These are patients that we should treat regardless. We'll talk about this in pain management. Your idea of a patient's pain is not relevant. It's the patient's level of pain. It's independent by every patient, and your perception of that shouldn't determine your treatment. Likewise, for these non-epileptic attacks, it's not incumbent upon you, the provider, to determine, yes, this patient's faking, no, they're not faking. Your treatment should be the same, and it should be based on evidence identified through a history and physical exam, through assessment. We treat our patients. And so if the patient is hypoxic, they should be treated accordingly. If the patient is having an epileptic event or a non-epileptic event that is causing underlying physiologic problems, that patient should be treated accordingly. As far as causes of seizures, it's not really known what causes all types of seizures. Most epileptic seizures are congenital. They're inherited from birth. They may not display until much later in life. There are structural changes that can cause seizures, and these are some of the things that we should be assessing for when we treat or see and assess a seizure patient, particularly things like underlying trauma or stroke. Metabolic seizures can occur, hypoxia, hypoglycemia, drug overdose, poisoning, sudden withdrawal from alcohol or medications. We'll talk about delirium tremens and alcohol seizures a little bit later. And then in the pediatric chapters, we'll certainly talk about febrile seizures. And these are sudden onset of high fever, primarily in children. And you will undoubtedly see febrile seizures in your career. These are often infant and or pediatric patients, and the presentation is hallmarked by a sudden increase in body temperature. It's usually from an underlying infection that has caused the patient to have a fever. But that rapid change in fever causes the seizure state in the infant, and treatment during the seizure event is just the same as it would be for an adult seizure patient, supporting oxygenation and ventilation if necessary. But it's more gauged in temperature control, right? So making sure the patient has access to antipyretic medications to try and control body temperature. That rapid fluctuation in temperature is what can cause that seizure in those children. A patient may be on any number of medications such as Dilantin or Keppra, Tegretol, Depakote, Topamax. All of those are at-home seizure medications, and you may, as a provider, be asked to assist with the administration of these medications, particularly in younger patients, infants, neonates, and young children, as they oftentimes need to be administered rectally, and the parents may not be comfortable with that or may have never done that before. And so it's not uncommon for EMS providers to arrive on scene and assist with those treatments. Recognizing a seizure, it's important, and you need to make sure that if a patient has an extended history of a seizure, you can provide some differentiating information. So was the seizure different than previous seizures? Did it last longer? Recognize the complications of seizures and the postictal state, and make sure that we're aware and we're assessing for those other underlying problems such as hypoglycemia or stroke, trauma that can be associated with seizures. The postictal state is the state after the seizure. You can see that you have the prodromal phase, the pre-seizure phase, the oral phase, that imminent awareness, the ictal phase, which is the seizure activity, and then the post-ictal phase. Typically characterized by lethargy and confusion. The patient should improve. It varies from patient to patient how fast they will improve. It's not uncommon to get a myriad of reactions from the patient. You may have things that where a patient is confused and disoriented and just simply asking a lot of repetitive questions. Don't try and assess the patient's orientation status immediately after their seizure. It's going to take some time. Be supportive, provide comfort care, use neutral tones of voice. You also should be prepared, though. The patients we've had, and it's well documented, that some patients can be combative in the postictal state. Usually as that brain fog clears, they return to a normal sort of cooperative state, but you need to be aware of that as the provider on scene. As far as assessment, seizures are most often, as we've discussed, they're self-limiting. You should protect the patients from injury to yourself, but under no circumstances be holding the patient down. You should assess the seizure and potential underlying cause. You can see they're gaining a temporal temperature here on this pediatric patient. As far as management, assess the airway, maintain O2 saturation above 95%. This is all supportive care. If the seizure is unbroken for a period of time, you may need to engage in ventilatory assistance. You should assess blood glucose levels post seizure event to make sure that the patient is not in a state of hypoglycemia. For advanced providers, paramedic providers, you may administer anti-epileptic medications such as Ativan or midazolam. Consult local policies and protocols for dosing and repeat dosing there. For pediatric patients, favor tends to go toward Versed or midazolam as opposed to Ativan. The reason being is the duration of Ativan in a pediatric patient is very, very long. And so we use a shorter acting medication for most pediatric patients. Ventilatory assistance may be needed, as we mentioned. Again, 1 minute seizure, a 2 minute seizure, that's not going to be a problem. But as we start approaching that 3 to 4 minute long seizure, you may need to provide ventilatory assistance. At the very least, provide passive oxygenation through blow-by during a seizure that lasts longer than 60 seconds. If you're concerned about the seizure during transport, make sure that you have an advanced provider with you and make sure that they are prepared to administer anti-seizure medications. You can pad the cot and the rails, ensure the straps aren't too tight. Again, you should not restrain a patient who is actively seizing. So you want to make sure they're safe but not restrained. Status epilepticus is a seizure lasting longer than 5 minutes or is unbroken by means of medication. These are true emergent patients. And if, as a general rule, if you arrive on scene to a patient, you were dispatched out for a seizure, and you arrive on scene and they are still actively seizing with no break, that is a status epilepticus patient. If you were a basic level provider, you should have advanced providers en route, and you should be prepared to be assisting ventilation with these patients. The reason being there, or the logic train, if you will, is that your response time is longer than 5 minutes. And if that seizure has gone unbroken during that entire period of time, that patient is hypoxic. That patient will be hypoglycemic. And there may need to be advanced procedures engaged up to and including chemically induced or pharmaceutically assisted airway management. As far as the pathophysiology for status epilepticus is concerned, these are seizures that last longer than 4 to 5 minutes, or they may be consecutive seizures with no return to normal cognitive function. And so it may be a tonic-clonic episode or a generalized seizure episode, and they may go 30 seconds and stop and never really become aroused, and then they may move back into that seizure state. The goal for this is to stop the seizure and ensure airway, breathing, and circulation. And so for the basic level providers, these patients, you should be providing bag valve mask ventilations. It's going to be difficult. You can't hold the head still to make a good face mask seal. So you're going to have to try and work with the movement of the body of the patient. Again, not restraining the seizure patient, but you're going to need to be able to ventilate while you're awaiting arrival of an ALS provider that has medication. First line treatment for medication, you'll have first line anti-epileptic or anti-seizure medications. This includes things like Ativan and Versed. You may have second line, so depending on your protocols and your guidelines within the service that you're in, you may have second line pharmaceutical agents that you can use for these patients, or you may be required to redose. If the seizure remains unbroken after first-line agents have been administered, paramedic providers should be considering advanced seizure treatment. And this typically includes drug-assisted intubation or rapid sequence induction, paralytics used for the medication. This is not going to stop the seizure. So a note for the paramedic providers here, when you engage in a patient, when you engage in RSI or rapid sequence induction for a seizure patient, just because you've given the depolarizing or non-depolarizing paralytic doesn't mean the patient has stopped seizing. You're just not seeing the seizure any longer. And what I mean by that is the medication you've administered stops the brain from communicating to the muscles. It doesn't stop the rapid firing of electrical activity within the brain. Okay, so your treatment there, you're securing the airway to be able to adequately ventilate and oxygenate this patient appropriately, but you need to still be prepared for the seizure activity to return as the paralytics phase. You need to still be engaging in pain management because this is a painful process, and you still need to be engaging in repeat doses of your anti-epileptic medication to try and limit the electrical activity that's occurring within the brain. And we've talked about this within pharmaceutically managed airway discussions before. You don't ever just push paralytics. You need to accompany that with adequate sedation and pain management. And the same rules apply for this patient here. The facilitation of passing the tube is solely for the purpose of being able to ventilate that patient and protect their airway. they're still seizing. So follow your standard care and guidelines. For advanced providers, you're going to administer your benzo of choice there. Be prepared to administer sedatives and paralytics if the patient is adequately seizing and is in a state of status epilepticus. Pregnant patients, just a note or an aside for pregnant patients, we don't generally give benzodiazepines to pregnant patients as they're pregnancy class D. Treatment for tonic-clonic activity at the paramedic level for pregnant patients, we will start with magnesium sulfate.